Post-MI management challenges, I think fixing coronaries is half battle done. Now we face with complications and challenges arising from complication of disease, secondary prevention and cardiac rehabilitation. We go into each. Arrhythmias, as we all know that acute MI is an arrhythmic substrate. Special troublesome are ventricular arrhythmias despite optimal revascularization. Of course, the treatments are beta blockers, balancing electrolytes, sedating to reduce sympathetic drive, cardioversion, IV amidron, IV lidocaine. If not responding to above treatment and recurrent episode, catheter ablation in resistant cases. Ventricular arrhythmias in the first minutes after successful reperfusion therapy can be transient without any treatment, may not require long-term treatment. Patients who develop atrial fibrillation in ACS, if they have pre-existing AF, they would need rate control, avoid CCB, use triple drug for anticoagulation, new onset AF, hemodynamic unstable, electrical cardioversion. And for restoration of sinus rhythm, in addition to cardioversion, amidron can be considered. Hemodynamically unstable, rate control, IV amidron. Of course, post-stenting, triple drug therapy will depend on the CHATS-VAS score and Hess-Bled score of the patient. And the triple drug therapy can vary from 1 month to 6 months depending on the patient's condition and the complexity of the intervention. Recommendations for management of new bundle branch block in AV conduction disorders, prompt opening of the infarct-related artery, especially true for AV blocks in the setting of inferior MI. Temporary pacing is indicated in life-threatening bradycardia not resolving after successful reperfusion. High degree AV block and intraventricular conduction defects. Permanent pacing is considered for disturbances that persist beyond the acute phase. When we talk of mechanical complications, these are papillary muscle rupture, ventricular septal defect, pseudoaneurysm, and free valve rupture. This is a summary of treatment of each and how to suspect. Papillary muscle rupture and acute MR generally happens in 3 to 5 days after transmural infarct. Presentation as acute pulmonary edema. Echo confirms the diagnosis. Management is surgical replacement or repair in select cases, preferably emergency operation within 24 hours with a very high mortality of 10 to 40%. Ventricular septal ruptures commonly 3 to 5 days after transmural infarction, especially late arrival, late PAMIs, late thrombolysis. Echo confirms the diagnosis. Treat the patient with afterload reducing agent. Intra-aortic balloon pump is recommended or LV assist devices if there are available. Urgent surgical repair timing depends on cardiogenic shock and end organ dysfunction. One could even consider transcatheter repair. Mortality is again very high, 30 to 40%. Rupture of free wall again commonly 3 to 5 days after transmural infarct. Tamponade and shock. Echocardiogram confirms the diagnosis. Immediate surgical repair with very high mortality. All these mechanical complications, including pseudoaneurysm, which can occur weeks to years after infarct, CT and echo can confirm it. Surgical or percutaneous repair is possible in such cases with a less than 10% mortality. All these mechanical complications require circulatory support. Cardiogenic shocks are went in great details. I won't go much into. Transcatheter support devices like mechanical support devices like IABP, which is commonly used and affordable in our country, whereas institutes which have possibility of having Impella or an ECMO, especially if the patient has undergone surgery, they can help the patients. These are the Impella especially can be used in PAMI with a complex interventions like left main intervention, similarly Impella RP. These are contraindications. I won't go much into in detail. ECMO, I would like to say a few words. ECMO is used preferred by surgeons, especially if it's a MI post-CABG situation. It gives biventricular support up to 14 days. You have retrograde non-pulsatile flow, high LVDP, may require additional measures to reduce LVDP. Complications like vascular complication infections are known. It is less costly than using Impella. These are other assist devices like LVS. What to do if there's a severe LV dysfunction? Of course, there are already different talks already about it. Persistence of severe LV dysfunction after acute MI is associated with high morbidity and mortality from both heart failure and sudden death. We must try to give them all pillars of heart failure therapy with ACE, ARB, beta blockers, MRA, and now we even use ARNIs if the patient's heart failure doesn't respond to routine drugs. Although Paradise MI trial did not talk of superiority of ARNI, but those who don't get better after ACE inhibitor should be put on ARNI, beta blockers, MRA, early institution of SGLT2 inhibitors, and SGC stimulators can also be used. Recommendation for implantable cardioverter defibrillator should be put in patients who continue to have LV dysfunction because they have shown survival benefits in patients with severe LV dysfunction. Secondary prevention. Regarding ICD implantation, there are now wearable ICDs available in Western countries, not available with us. Currently, the guidelines tell us to put it after 45 days of an acute MI. Regarding secondary prevention among patients who survive, 20% suffer a second event in approximately 50% of major events occur in those with previous hospital discharge diagnosis of IHD. So goal of secondary prevention is to control risk factors. Hypertension be controlled with the exact European guidelines of BP of less than 140/90. HbA1c target of less than 7 for control of diabetes, and the emergence of SGLT2 inhibitors and GLP-1 receptor agonists is a significant step forward in secondary prevention following MI in patients with diabetes. There are strong recommendations for dyslipidemia. Statins, high-dose statins, extremely to be used in all patients. And if the goal of less than 55 is not achieved, then ezetimibe should be added. And if still the goal is not achieved, then PCSK9 inhibitors or bempedoic acid should be used. Apart from these risk factors, consider cessation of smoking, weight control, continuing antiplatelet therapy, low-dose anticoagulants in polyvascular disease patients, and stress management. Very important point is to send the patient back to his normal routine after an acute MI. Most of the patients go into a depressive phase. Cardiac rehabilitation helps for early reception.
Your time is finished. Okay, you take another minute. Okay,
yeah.
Please finish by.
So cardiac rehab helps in early resumption of normal life to these patients and should be recommended if available. Most of the patients can be safely sent back to their jobs between 6 to 8 weeks. And important thing is to remember that after an acute MI phase, the coronary management is only half the battle. The remaining battle is with their post-MI management. And if that is done well, the quality of life of patient improves and he can go back as early to his normal life as possible. That should be the goal of a cardiologist. Thank you.